Obstetric emergencies present with sudden, violent shifts in maternal physiology. A stable patient can transition into hemorrhagic shock or eclamptic seizure in seconds. In these windows, maternal survival depends on a physician's rigid adherence to quantitative decision algorithms. This module maps the 3 high-stakes pathways where these algorithms are most critical: hypertensive gestational cascades, postpartum hemorrhage, and early ectopic pregnancy. Success in these scenarios requires identifying the specific physiological triggers that dictate action and recognizing the contraindication traps that make standard protocols dangerous for certain patients. Preeclampsia manifests as a systemic collapse of the maternal endothelium. Clinical evidence shows the pathology begins with an abnormality of the placental spiral arteries and poor trophoblastic invasion. This prevents normal vascular remodeling, causing high-resistance placental hypoperfusion. The ischemic placenta then releases vasoactive hormones, triggering generalized endothelial dysfunction, hypercoagulability, and vasospasm. This vasospasm defines the initial diagnostic fork. A blood pressure of 140/90, measured after 20 weeks gestation, indicates gestational hypertension. The presence of proteinuria confirms preeclampsia. A maternal blood pressure reaching 160/110 marks the immediate threshold for severe features. Laboratory findings also escalate the diagnosis. A platelet count below 100,000, or the doubling of serum transaminases, mandates a classification of severe preeclampsia. New-onset cerebral or visual disturbances, such as blurred vision or severe headache, serve as final clinical triggers for this classification. When severe features are present, initiating IV magnesium sulfate for seizure prophylaxis is an absolute clinical mandate. Do not delay magnesium administration to wait for a 24-hour urine collection. The risk of eclamptic seizure requires immediate intervention based on the existing severe markers. Magnesium therapy requires vigilant serum monitoring. Toxicity begins with the loss of deep tendon reflexes when levels reach 7 to 10 milliequivalents per liter. If serum levels climb to 10 to 15 milliequivalents per liter, the patient is at immediate risk for respiratory depression. Reversing this toxicity requires halting the infusion and immediately administering 10% calcium gluconate to stabilize cellular membranes. Effectively managing preeclampsia requires acting on these specific quantitative thresholds to prevent the progression to fatal maternal seizures. Postpartum hemorrhage is defined as blood loss exceeding 1,000 milliliters or clinical signs of hypovolemia within 24 hours of delivery. Uterine atony is the primary driver of this hemorrhage. The myometrium lacks the tone to physically compress the bleeding spiral arterioles in the placental bed. The first-line intervention is aggressive bimanual massage combined with IV or IM oxytocin. If oxytocin fails, the algorithm moves to second-line pharmacological agents, where maternal comorbidities dictate the choice of treatment. Methylorgonavine acts as a powerful smooth muscle constrictor to increase uterine tone. It is strictly contraindicated in patients with hypertension or preeclampsia, as it can trigger a catastrophic hypertensive crisis. The next option, carboprost, is a synthetic prostaglandin F2 alpha analog. It is strictly contraindicated in patients with asthma. Administration will induce severe, potentially fatal bronchoconstriction. When these agents are blocked by patient history, sublingual or rectal misoprostol serves as the safe alternative. Treating postpartum hemorrhage requires matching the pharmacological agent to the patient's specific clinical profile to avoid secondary systemic crises. Ectopic pregnancies occur when a blastocyst implants outside the uterine cavity, most frequently in the ampulla of the fallopian tube. The initial clinical decision is determining if the patient qualifies for medical management or requires surgery. Methotrexate, a folate antagonist that halts trophoblastic cell division, is the primary medical option. Medical management requires meeting 4 strict parameters. The mother must be hemodynamically stable, and the ectopic mass under 4 centimeters. There must be 0 fetal cardiac activity, and serum beta-HCG under 5,000 microintern IU per milliliter. Breaching any single one of these 4 thresholds mandates an immediate shift to surgical management. If a stable patient has a 3.5 centimeter mass and no fetal heart tones, but a beta-HCG of 6,200, the medical path is closed. This outlier forces an immediate laparoscopic salpingectomy, regardless of other parameters. Ectopic management is governed by these ceilings. One data point can fundamentally alter the standard of care from pharmacology to surgery. Consider a patient at 36 weeks presenting with severe epigastric pain, hyperreflexia, a history of chronic asthma, and massive hemorrhage following delivery. A blood pressure of 165/115 combined with her epigastric pain confirms severe preeclampsia. This finding mandates IV magnesium sulfate and immediate blood pressure control. When uterine atony causes massive hemorrhage, second-line pharmacological escalation becomes necessary. In this patient, methyl-ergonovine is dangerous because her preeclampsia creates a high risk for a hypertensive stroke. Carboprost is also contraindicated due to her history of chronic asthma, as it could trigger fatal bronchospasm. Misoprostol is the only safe second-line agent remaining in the algorithm for this specific clinical intersection. Safe management in obstetrics requires identifying the specific points where separate emergency algorithms intersect, ensuring overlapping treatments remain safe for the individual patient.